My name is Lori Lozon-Clabo. I'm the Dean of Nursing at the MGH Institute of Health Professions. The Institute has a long-standing relationship with Connected Health, and we are pleased to be part of this year's meeting. It's my pleasure to welcome you to this morning's panel on accountable value-based care. I'd like you to join me in welcoming the moderator of our panel, who is Jane Saracen-Kahn. Jane.
Well done. Thank you. Thank you. Hi, everybody. Good morning. Thank you for coming to our session. I'm sure it will be the best of the three. So I'm happy you're here. I'm a health economist, and I'm married to a banker. So my life is all value all the time. And if you're my teenage daughter, you're not always happy with that in the household. Because I think about value in health a lot of the time with whatever stakeholder I'm working with as a healthcare consultant, I am concerned with what Donald Berwick talked about this morning, that $1 in every 5 in this country goes to health care, and a lot of that goes to waste. We heard yesterday poignantly, some of us very verklempt when she told us about her situation. That was Wendy Everett and her husband's last 5 months of life in the health system. And this was with an engaged patient and how much waste there was when you try to engage. So it's a major issue, and that's why this panel's convened to talk about the issue of value and innovation, coupling that, and how do we thrive? Because in a constrained economy, which healthcare is, developing innovative approaches to healthcare in this kind of a system is a hard thing to do with regulatory constraints and licensing constraints and other things conspiring against that vision. Yesterday, if you were here, you saw Amy Cueva from MadPow put up a graph of constellations, of stars in the sky. And there were hospitals and pharmacies and pharmaceutical companies and social workers and patient advocates. So that ecosystem is the kind of paradigm we're going to talk about here. And we have 3 kind of stars from that ecosystem represented on this panel from 3 different segments in the industry. And these kinds of segments, I was talking to Dr. Kvidar when we were conceiving this panel, these are the kind of folks I wanted to see convene at the Connected Healthcare Conference, because these kinds of stars in the galaxy can help drive innovation in concert with patients and providers, and you don't always get these kind of folks on a panel at a symposium like this. So I'm really pleased to be part of this panel. We're going to start and kick off with each of our panelists telling us their views on who they are in the healthcare ecosystem and how they look at value through each of their lenses. So we'll kick off with Jeremy Dolinsky from Athena Health.
Good morning, everybody. Thank you for having me. I'm Jeremy Dolinsky. I lead the research and development organization at Athena. So that's primarily software development and user experience design. And for those of you who don't know Athena, we're a cloud-based health IT platform that are used by about 45,000 physicians across the country in the ambulatory environment. Thinking about value, thinking about innovation, I'd say that the Athena take on it and my personal take on it, it kind of goes back to our roots, which is actually we started as a medical practice. So the Athena Health first business model was one of owning birthing centers in underserved population areas in San Diego County and in Rhode Island and in Connecticut. And we set out to be best in the world at getting paid for doing the right thing. And we were unbelievably good at lowering NICU days and delivering OB episodes at a very low cost. And we ran out of money. And so this was the last time the provider management business cratered and risk went out, and we became an IT company instead. But we still approach the world from that lens, which is that we want to be best in the world at getting doctors paid for doing the right thing. And doing the right thing in today's world is figuring out how to manage populations, how to reduce waste, how to have a patient experience that is dignified and worthy of the amount of money we spend in healthcare. And to help do that, we really have 3 points of view. So I think one is that cloud-based systems will win in the long run, not because it's somehow better to be in a web browser, but it's simply because we get to do a release of our product every month. And so the ability to change as healthcare is changing must mean that your platform can change weekly, daily, and certainly monthly. The other thing is that we owe it to the users of our systems great user experience and design for physicians, design for patients, which I think most health IT systems lack today. And then the third is that I think we've decided to fundamentally mature our view on what it means to be a health IT provider, which is that when I used to hear about innovative things happening in other companies, my first reaction was, oh, we can do that, and we'll build something competitive to that. And I think what we've come to realize is that we're Joy's Law, which is that no matter who you are, most of the smartest people in the world work for somebody else. So no matter how many brilliant developers we hire away from Google or brilliant MIT engineers, there are always going to be more people out there working in health IT who are going to do innovative things. And instead of fighting that and being resistant to them coming and knocking on our door and asking for data from us or integration with us, we've decided to approach it openly and to say, come in, we'll show you what our APIs look like, and let's figure out how to help doctors get paid for doing the right thing.
Great, thanks. Scott?
Good morning, everyone. I'm Scott Howell. I'm a Senior Vice President of Clinical Affairs in the Specialty Business Unit at Cardinal Healthcare. Cardinal is a representative of the supply chain side of healthcare, and I'll be here sort of representing our view today. Cardinal's a big business. We operate at scale. We're a Fortune 20 corporation, around $100 billion a year in revenue, 34,000 employees, mostly here in the U.S. We do have some operations in Canada and in Puerto Rico and in China as well, but we're mostly a U.S. healthcare business. Our mission actually is we think of it in terms of making healthcare more cost effective, and so this is at the very center of what we're about, I would say, improving value in healthcare. We do that mostly through business-to-business relationships, although we do have a number of business-to-consumer, business-to-patient relationships, which is actually a growing area for us. And we're not just about distribution. Over time, we have been invited by the customers that we serve to migrate into some adjacencies. And so now we provide a variety of service offerings, consulting, software, data and analytics, and the like as well. Again, all centered at making healthcare more cost effective.
Josh.
I'm Josh Seidman. I'm the Managing Director of Quality and Performance Improvement at Evolent Health. Evolent is a company that helps large provider-based delivery systems move from being focused around the turnstile, around volume-based care, and to moving to being fully accountable for population health. So we really take on virtually every aspect of that transformation. And I would say that there's sort of three main opportunities that we see. Because we're working directly inside the delivery systems as partners, long-term partners with these delivery systems, what we're able to do is really work as a team with those clinicians. The second part of that really is the corollary to it, is because we're working directly with the providers in the delivery system, we can directly engage with the patients, their families, and all the people involved in managing their health. And then the third piece, and it's actually related to the first two, is that it is really around the data. And it's the opportunity to not only be leveraging the administrative data, but because we're working with the providers, to leverage data directly from the clinicians, the EHR data and other clinical data, and then to leverage the data that's coming directly from patients. Certainly we're doing that already a lot with HRA, health risk assessment data, and we're going to begin very soon to collect a variety of patient-reported data, and we're going to use that as in sort of three ways. One is around stratifying the population, identifying risks, et cetera. The second is around tailoring interventions and tailoring care needs, tailoring to care needs. And then the third is to measure outcomes and improvement.
Great. So we've covered one half of the value and innovation side of the equation. Let's talk about the innovation side now and define that. And I want to talk about a definition I don't like first that I heard 2 weeks ago at the Cleveland Clinic Innovation Summit. And nobody's really agreeing on what this is. That's why I really want to hear from you guys on it. So I won't mention this person's name, but she is from a Fortune 10 company, and who's very active in healthcare. And she said, quote, "We are innovating faster than we can get things through the system." Now, to me, That's sort of, I have a whiteboard and doesn't this look cool? And it works in an office in Silicon Valley or on Pill Hill near Cleveland, where Cleveland Clinic is. But if you can't get an innovation through the system, then to me, it's not very innovative. So I'm going to kick it off with that, saying, guys, let's get real about these definitions. So who wants to take up the innovation question first?
So I'll
Yeah,
take a shot.
Scott.
Yeah, so, at Cardinal, from where we sit in the supply chain and our interactions with doctors and hospitals and clinics and pharmacies and patients really across the nation, and because of, really what we bring to that market, it really is all about scale for us. So for us, I would say our business generally, and including particularly, I would say, innovation, is one where scale matters. And I wouldn't say that we wouldn't rule out, kind of some smaller, cool ideas and things that might be more interesting in some locales than others. But when we think about what we get really excited about, what we're really good at, it is solutions that can launch at scale. There are some challenges, obviously in the marketplace today with those things. And some other tests that we think about as we look at innovative solutions, Jane. I think, innovation starts with creativity. We have a lot of creativity at Cardinal, and there's a lot of it in the marketplace, and, that doesn't really seem to be the biggest challenge from our perspective. Increasingly, what we're being asked to do by the folks that we serve is go beyond just a creative solution, but give me a solution that is integrated. They want to see solutions that span across departments and line of businesses at Cardinal in new ways, right? So it's not just a solution for my pharmacy, it's a solution around population health management and the like that cuts across different parts of Cardinal, but importantly cuts across different parts of their organizations as well. And those integrated creative solutions are more challenging. But even then, I'd say, usually we can work our way through that and figure those out. And I think increasingly what we're seeing where the larger challenges are, and I'll say I'll call them collaborative solutions, and that's where the cooperation that's needed goes beyond the walls of the enterprise. It goes, out into other enterprises, if you will, and that's where the hard work really starts. That's lining up not just, the players within the hospital, but also the pharmacies in the community and the nursing homes or the doctor's offices to work in new creative ways to bring innovation and bring value at scale.
Mm-hmm. We heard something about that from CVS yesterday afternoon, if you were in the room, where the chief medical officer is saying, we're CVS and we have Caremark and we're still having problems connecting. So it's a formidable challenge that you're talking about.
Is.
Josh?
Yeah, so we think about innovation. I know, Jane, you like mathematical equations, being an economist. Something of a mathematical equation, which is that innovation equals the combination of creativity and execution. So I agree, it starts with creativity, and then there's the question of is it something, is it a good idea, or is it something that you can execute? And that is, a lot of great ideas kind of end there. And sort of the idea that you'd be innovating faster than you can, I can't remember the end of it, but
get it into the system.
Get it into the system suggests that, from our perspective, that they actually haven't. They've come up with a lot. They're creating. They're being creative, but they're not actually innovating because they're not executing on that. So I think that what the big part of it then is figuring out where are the ways then to not only to execute on it, but then to scale it. I would agree with that.
Got it.
I think coming at it from the software perspective, I would say that innovation is not features. And so if you look at most health IT solutions out there today, they generally have feature parity. But then what accounts for one successful install or a failed install or someone getting meaningful use or someone failing or someone succeeding in the Pioneer ACO program or failing? And I think I think that people oftentimes look too much for software and not enough for service. So when I hear someone say that we can innovate faster than we can get it into the system, then what I would say is, well, then stand up a service center to do the work instead. Right? So you can either have the software do it in an automated way, or you can throw labor at it. And I think when you look at some of the true sort of innovations that we've come to love in our personal lives, look at Amazon and what they've done. It started fundamentally as a service business with a business result in mind, which was delivering content to you at your house. And it turned into lots of different kinds of content, and it turned into sending it via the mail, and then it was UPS, and then it was just digitally through 3G. And I think that that's what we have to think about more and more as healthcare. We're going to need to innovate a lot faster than most people are going to be able to update their systems. And so how do you ensure success by actually just to measure what you're trying to go after and focus on that, not the litany of features that will help you get there. And I think that is where I think lots of organizations fall down, quite honestly.
So just to follow up with you, Jeremy, in terms of innovation at Athena Health, and I know the company because I do a lot of work in health IT. So when I think about your secret in your sauce, maybe, it's not a secret, it's what you do with the cloud that other health IT companies, big ones, incumbents, aren't doing. Could you talk just a minute about cloud as part of the innovation secret?
So I think I started with the idea that one of the great benefits of cloud systems is that you just they're platforms that you get to release very often, right? So that is a really nice thing, and it's different than installing software. But the other thing is that when you have lots of different people using the same software package in the cloud, you all of a sudden start to see patterns of good use and patterns of bad use. And you start to be able to aggregate data at far greater scale than any of the individual users or organizations within that cloud would be able to do on their own. And I think there's been a lot of talk in healthcare about sort of the need for learning systems. I think Intermountain Healthcare probably has the most famous one that all of us are familiar with. But I think that really is a key part of how we've innovated, which is is to actually just monitor the use of the system in the wild and to understand, gee, why aren't providers giving clinical care summaries at the end of a visit? And what can you do to interrupt the workflow to make it more likely that they will? And so monitoring that usage and mining it across everyone's what we call a table space has been a huge part of that. So it's the cheapest way of data aggregation and data acquisition that I can think of that exists today.
And cheap can also be value.
Yes.
So I'm listening. So let's strive now and marry this value and innovation concept to costs in the healthcare system. Because, I don't know if you've all played WhackaMole with your kids or played it as a kid, but it was one of our favorite games with my kid who could get her aggression out when she was little. I think she still could benefit from it as like cognitive behavioral therapy. I don't know. You can tweet that and she'll see it. But healthcare in America has often been visualized as a whack-a-mole game. So I've been a healthcare consultant for over 20 years in the States and in the NHS, so it was fun to see Mr. Key here for yesterday. But if you whack down one segment of the system and say we're going to control costs over here, then costs magically seem to raise in another segment of the industry. And one of the earliest experiences I had with this was in the ambulatory surgery businesses that popped up in the late 80s when I was starting out as a young consultant. So you moved surgeries down from the inpatient setting and moved them into the ambulatory surgery setting, either at a hospital-owned unit or at an ASC, an ambulatory surgery center. And magically, costs over here just rose to make up the difference of the fall here in this US healthcare system. So in a value-based system where you want everything to stay at least even, the way Berwick was saying, let's just redistribute if we stay even, how do we innovate in a whack-a-mole system where one stakeholder's revenue is another's cost? Who wants to grab hold of this one first?
So
Go ahead.
I'll take a shot at that one as well. So for me, what comes to mind, Jane, is this is back to the notion I shared of collaborative, innovative solutions, but solutions that go beyond the enterprise that involve actions of more than one moles in your game, yes. I would say. And I think that's the answer to that. I think in many respects, some folks have described healthcare as sort of in terms of game theory, that we have large, powerful, vested actors, who have optimized relative to each other, and the first move for any of them may be thought of as a give up for them, and so they're reluctant to do so. So they're optimized locally, but the game overall is sub-optimized, and the theory goes for that we have to change the rules or you have to change the finances, and I think those are the kinds of changes that can start to get folks behaving more collaboratively, folks beyond the enterprise behaving more collaboratively, and lead to the kinds of solutions that aren't so much, whack-a-mole. We're seeing it in the specialty business right now, in specialty pharmaceuticals, in sites of care shift, right? So that one of the recent squeezes has been about reimbursement to physicians in recent years on infusing products in their offices, and so almost predictably, we're seeing a site of care shift to the hospitals where the costs are actually, substantially higher. It is true that better solutions exist. We have some examples of that at Cardinal, and one that we have is an oncology pathways program that works with payers and works with their physician networks to agree some approaches to preferred care, to pathways for care, and then changes the financial incentives in a way that rewards them to do that. And so we've implemented these at a number of payers across the country and lots of practices, and we have some published data now that you can save up to 15% or so while patients are getting better care and doctors are being paid in a way that actually is kind of more per unit of activity rather than less.
Great, wonderful.
So it is possible, but it's not easy.
So I just make 4 observations. So one is I think this, a lot of what in the past we as a delivery system have tried to do is to implement a program to attack some problem that we saw, and that's where you start the whack-a-mole game. And rather than doing that, thinking about a model, a population health model that is focused around a set of clinically integrated initiatives that all serve to support that model. So that's sort of the first sort of big picture thing. The second thing is that it's really got to be a long-term horizon, and that if it's a year-to-year cost savings effort, you're going to end up doing really well on one thing one year, and then you're going to have some regression to the mean, and the next year you're going to have a whole set of other problems. So being able to look over a multi-year horizon is really important. The third thing is the measures. Having been developing quality measures for a long time, I really, I can't emphasize enough, we have to continue to evolve the population health measures that can really guide us to things that will get at care coordination and true engagement of patients and their families, things of that nature. If we don't do that, we're not going to be getting at some of these longer-term cost control outcomes. And then the final thing, though, just to say is, and it relates to something that Dr. Berwick said this morning, which is this transition state issue. And it's something that certainly at ONC, transition state was a big thing for clinicians. Certainly from where I sit now, for large delivery systems that have made this commitment to moving toward being fully accountable for population health, I agree with Don that we need to we need to move beyond pilots, but you can't just flip the switch on a delivery system and go from one to the other in the matter of a year. And so large delivery systems that have made this commitment, they still may only have in their first year 5 or 10% of their business at risk. And so it creates a set of challenging and conflicting incentives as they're trying to make that transition. That's a tough place to live. And so, the quicker we can make the transition, but that also requires us to be quicker in moving to stage 2 meaningful use. It requires, so we can have the connectivity that was discussed yesterday, so that we can do those kinds of things as well.
I mean, I think that there are elements of a zero-sum game to some extent, which are hard to avoid. So if you read the reports, it would suggest we have what, 50% too many hospital beds in the country than relative to what we need. And I think when you have something that's structurally off, there will be people who lose. But I don't think that, but then you balance that with, you know, as we're just trying to lower the rate of inflation of healthcare and sort of lock in its current size forever. So there's a lot of money and a lot of capital that can fund innovation as a result of that. I think that ultimately what it might come down to is, you know, not being afraid of competing based on something other than brand, right? So I think that quality, if you're a consumer, you can't shop for anything in healthcare, right? And I think certain things you'll never be qualified to ever shop for in healthcare because you won't know. But there's almost none of it that happens today in any way. And I think that as this zero-sum game plays itself out, I think organizations will have to think about what are they better at than everybody else, and what are they willing to let go because it might be done somewhere else for less money, but the opportunity cost of doing that service is lower than what you get from what you're best in the world at anyway. So, you know, that's, I think the other reality is that every hospital executive is probably looking at, you know, operating margins in the future. You get a plan for a world where, you know, certainly the reimbursement from Medicare is going to put you at, what, a 20 to 40% operating loss? Yeah. And so no matter what game you play now, you have to think about every year how you take reasonable cost out. And, you know, I think all you have to do is look at the patient experience in any healthcare setting. And if you approached it from that view, you'd probably see tremendous opportunities for efficiency, just like we've seen in every other industry, like banking or air or big box consumer electronics, that if we really streamlined what it felt like to be a patient, I think that cash would be falling out of the walls, quite honestly.
Yeah, I take airlines out of that because yesterday I saw on Morning Joe they're making airline seats and coach even smaller, so putting one more seat in the back. So we can't use airlines anymore, I think, for patient experience. Patient experience is part of the triple aim, as Dr. Berwick talked about. So let's riff a bit on that holy grail, which is reducing per capita costs, which he said, enhancing experience, and Josh's world, driving population health outcomes. In a value-constrained world, how do we get to triple aim through each of your lenses? And we only have a few minutes, but I mean, this is like the question. Josh, you want to start?
Sure. So, I mean, the way we think about it is really thinking about the value proposition for both the patients and the physicians and other clinicians. And they roughly match up to that triple aim. So better care, absolutely. And the critical pieces of that are making sure that communication happens between episodes of care so that everybody has information about what is going on with that patient's entire experience. Team-based care, and in that team, that everybody on that team is practicing at the top of their license. So much of care either doesn't need to happen in the office or could be happening, it can be performed by people with other backgrounds. And then respect and collaborative care, and the need to ensure that both patients and physicians feel that they are respected and part of a collaborative atmosphere. So that's the better care piece. The value proposition on sort of better health, better experience, really actually in many cases comes down to making lives easier. Making lives better, making lives easier, changing the experience overall for patients and physicians. So available and meaningful information when you need it, where you need it, how you need it, totally changes that experience on both sides of the equation. Making sure that people have easy access to all the care team members. Again, this is for both providers and patients because patients obviously have this tremendous barriers in many cases to getting access, but so do clinicians. They can't identify who even the primary care physician is for this patient that came to them in the hospital or something like that. And then making sure that they have effective and user-friendly tools for managing an overall plan of care. And then finally, on the cost side, it's really about thriving in this new world. So on the patient side, as they're saddled with more and more out-of-pocket costs and more burden related to cost, that's becoming an increasingly challenging thing. For physicians, just maintaining that stability requires a remaking of those financial and reimbursement relationships. For both parties, a lot of it then comes down to being able to do that in a context where they can preserve those personal relationships that they already have, if they so choose, and to be able to move to other ones if they decide that they want to do that. And that both parties really need to have ownership in that redesign process. That is a critical piece of being able to ultimately control the cost, because that's where people feel that they have created the solutions.
Great. Scott?
Yeah, so I would say that, so we're talking about value and the triple aim. And Don said earlier that, ultimately the money comes out of we the people. And, really the value is defined by, we the people as well, including both, importantly, as patients and as consumers. And so I think the value is rooted in that equation to patients, to consumers. On the supply side of it, we've talked about the importance of innovation already, the need for collaborative solutions that go beyond a single enterprise, the difficulties in getting to that, and sort of the need to kind of change the rules of the game to achieve that, and change the financing of the game to achieve that. And we have some of those things happening with, Affordable Care Act and ACOs and pay for performance and shifts in risk and all those kinds of things. I think on the demand side of the equation, Jane, again, this will root you back in the patient and consumer view. That's critical as well. And we at Cardinal, we're trying to serve that point of view. We actually have, we do have parts of our business that connect directly to consumers, and we recently made a big purchase for another company that does delivery to the homes as well. When I think beyond our business at Cardinal and how we think about engagement of consumers, I think of Cardinal as an employer. And we have a lot of programs, I think, that are kind of in the mainstream of that. We're moving towards consumer-directed health plans with all the usual tools that are associated with that. We provide a lot of workplace health and wellness interventions. So you can do HRAs and get biometric screenings, and we have a fitness center and health coaches and all those kinds of things as well. And then we have financial incentives that back all those things up as well, that encourage people to sign up for these things. And they're being really effective. We're over 3/4 of our employees now are participating in the programs. Slightly over half of them are finding some new or under-addressed condition. And more than 2/3 of those are signing up to do something about it. And so I think the consumer is critical in this. It's part of the definition of value. And we need to, we're serving that, I think, in our business at Cardinal, but we're also thinking about it from our perspective as an employer.
Great.
I feel for physicians right now, because I think the pendulum has swung a little too far back in the direction of it's the physician who will do for the patient. And back 10 years ago, the rage was consumer-directed healthcare, and it was that the consumer would do. And I think there's probably something in the middle that's going to work. I think what it comes down to, it's really hard to get behavior change among people who aren't motivated to change. And also some of the chronic illnesses in particular that we're so concerned about, given the cost, they're hard to treat, right? So when I look at, we have about 40 million patient charts sitting in our system, and we looked at, of all the diagnosed diabetics, what percentage of them had controlled A1C levels, and it was 10%. And so what that tells me is, guess what? It's probably hard to treat diabetes, right? So I think that I come maybe to something that Josh was saying, which maybe it does come down to being easy to be found. So one of the things that struck me very recently when I was looking at the data was that it's roughly 15 to 20% of all the web traffic in the world happens on a mobile device. 35% of the web traffic on our patient portal happens on a mobile device.
How much percent?
35%.
Wow.
So patients are dying for easy ways to interact with their physicians through mobile devices. They are flocking to convenient urgent care centers. They're flocking to MinuteClinic. And so I think that, what's the best way to maybe spark a behavior change in somebody would be sort of catching them at that moment where they're open to it. And I think the other thing is interesting is that I think there's something about the anonymity of doing some of these things digitally that, we looked, for instance, people are more likely to pay their copay if they do it on a kiosk rather than if somebody asks them for it. So there's something about sort of harnessing these consumer interactions that people are used to doing in their private life and figuring out a way to kind of be convenient for them and kind of experiment with different ways of what might spark them. And I think that there aren't a lot of platforms in healthcare that really make it easy to do that at large scale, to see what might work and what might not work. We've done these sort of very heavyweight sort of population management efforts through payers, where people call on the phone, and I'm never home to take a phone call on my landline from anybody. And I bet most of those calls from payers go to people's landlines, right? So I think we have to just rethink how the mode of engagement and how to catch more people.
So let's make this our last question before we go to you all, and we would love questions from you in about 3 minutes. So continuing off what you just started, Jeremy, to Scott and Josh, how do we get patients, people, caregivers in the middle of the triple aim? What can we do? We hear about engagement in almost every session in the last couple days. So what is meaningful health engagement in the triple aim? I agree with you. Paying bills on kiosks really help physicians' financial wellness. But how do we think about patients then in the middle of the triple aim and how to engage them in their own care, the most underutilized resource in the health system, right? So Josh, in doing your population health visions right now, and I know this is early stage for Evolent, what kinds of whiteboarding are you doing on working with systems for patient engagement?
Yeah, well, for us, really a lot of it is about engaging somebody else before we engage the patients and the families.
Okay.
So that very well may be the physician, it may be a care advisor, a health coach, it may be a peer who has already been experiencing that. But it's very hard to get an individual who is unengaged directly engaged if there's not another person who's really. Now, I shouldn't say it's always very difficult. There are some people who that can be motivated through other things or respond better to technological things, but in many cases it's going to be some other human being that's going to help them, and we have to figure out how to engage those people. And that was, I know, a theme that we heard yesterday afternoon.
Scott, you said Cardinal bought a consumer-facing company in terms of delivery to the home. What kinds of initiatives might you all be involved in being a little more consumer-facing, a little more sort of retail about Cardinal's approach to health?
Yeah, so this is a business that delivers medical supplies to the home. And we have a fundamental belief that the consumer is more important for more and more important for the future, and that we want to serve those folks, but we also the businesses that we serve, that we help stand up, interact with them, and need to serve them as well. And so we want to assist them in doing that, as we talked about earlier, in a more cost-effective way. And I think for us, the point of view is kind of, I'll paraphrase what Jeremy said, but you got to meet them where they are, and whether that's in the home or in the community or on the web or on their mobile device or at the doctor's office or the grocery store, then that's where we need to be prepared to go.
In your previous lives, you worked in pharma and biotech. So the issue of medication adherence is another holy grail, little h, but it's part of driving value and cost down. So how hopeful are you that some of these new technologies that we're seeing, mobile, behavioral economics in the plan, and you've also been in the health world, are you more sanguine, more optimistic about this?
Well, it's both. I think you have to be hopeful and realistic at the same time in healthcare. You can really apply your shoulder against the wheel really hard for a long time to see, a little bit of movement. But in the big picture, you're talking about lots and lots of people, a little bit of movement, really matters. And I think these tools are great. my daughter's taking a medicine now, and you know, we got her something as simple as a little physical, you know, pill box labeled with the days, and it's working great for her. She,
Sure.
you know, and that's meeting her where she is. She's in 5th
Appropriate
grade.
technology.
Yeah, exactly.
Yeah.
But for lots of other folks, you know, meeting them where they are is, you know, all these other channels as well. And so I don't think it's one versus another. It's, you know, it's not quite all of the above, but it's the right one for the right need.
Do you want to add, Jeremy, to what you said before?
Yeah, I mean, I think one other thing we're thinking about is how does an electronic health record become a shared tool between a patient and a provider?
Yeah.
So the first generation of EMRs were not designed for a moment where you would turn around the screen and show something to a patient. With, you know, maybe a pediatric growth chart would be the one exception to that in most EMRs. And so if you at the moment of you were, say, ordering something, you could turn around the screen and, you know, have a conversation about, well, here are the drawbacks of this treatment, or here's a provider who might be more conveniently located to where you need to be, or here's what your insurance plan likely will cover or won't cover, and engage the patient in how the physician's thinking about what they're supposed to do next. That's one thing we're thinking about, and explicit sort of, we call them turn the screen moments, where you're designing the software for that purpose and that use. You know, that's small, but it might be some sort of way station along the way.
I don't think it's small. I think it's a moment of truth. You were saying earlier consumers don't know how to shop for healthcare. I think that gets them smarter about shopping for healthcare. If you can show a brand versus a copay, for example, price and a location for that, or prescribe an app.
Or imagine if you could self-schedule, you know, into that next,
Right.
at the moment of a referral, right? And so opening up provider schedules to all the iTriages, to the ZocDoc,
ZocDoc.
everything. That's another thing that we're working on.
Yeah, that's exciting. So do we have questions? Hello, it's hard to see up here, I'm sorry.
Hi,
Hi.
thanks. My name is Lynn Paget, and I'm currently directing a project that's a collaboration between the National Committee for Quality Assurance and the Gordon and Betty Moore Foundation around leveraging health IT for patient engagement. And several issues are on the table, and this will have to do with some of the investment that the Moore Foundation makes in this area. NCQA is sitting at the table, of course, because they're very interested in metrics and measurement that help move the needle of quality in healthcare in this country. Josh, you mentioned measurement as kind of one of the cornerstones in your, and there hasn't been a whole lot of conversation yesterday or today about measurement, but it is an important part of the ingredients that have to bake into the pie for us to really create sustainable models. So I just wanted to ask the panel, I believe we are at a juncture where measurement has to become much more creative and innovative. And I'd love to hear any comments that about the current measurement that you might be doing, or any insights that you have that would help inform this project about what kind of metrics would be helpful to really make this a reality. Thank you.
Well, I absolutely believe that I mentioned needing better measures of things like care coordination, patient engagement. So one of the things, for example, that we believe is really important is to really understand what true patient engagement is. I think the best measure out there for that right now is the patient activation measure. And I think that, and so we are going to use that as our vehicle for right now to understand that. To understand improvement levels, because the PAM has been linked to a variety of improvements in everything from intermediate outcomes to cost, to utilization and cost. We also need to get to measures that really recognize where a population is and where they're starting from. So, for example, in stage 2 meaningful use, there's a new measure that is designed to leverage new technology, measures that we couldn't have done before. So rather, for example, than looking at blood pressure as a simple binary question of, was the blood pressure below 140, below 90, a longitudinal improvement for individuals. And so we know, for example, that there's much more benefit from a quality and a cost standpoint in bringing a patient with hypertension down from 160 to 141 than from 141 to 139. But that's not how we give credit in this delivery system. So when we think about how we leverage new technology, we should really be thinking about things that, that really are HIT-enabled measures that we couldn't do before.
So my comparative advantage in the world is not designing clinical measures. What we have focused on is the speed to deploy them. So one of the most depressing things that I heard in the last couple of years was when I was on a panel in Washington, and it was ONC asking industry perspective on how long should it take us to build new measures into our systems, and what, from a health IT provider's perspective, what is the needs we have around harmonization? And what I said is, well, we don't have a need around harmonization, and we should be able to deploy these measures nightly into our base. And what I heard from other vendors was, it'll take us 18 months to deploy a new measure, and we must harmonize all quality measures across all programs. And when I think about the challenges in healthcare right now, who knows if we're measuring the right stuff? I suspect some of it's right, and I suspect some of it's not. And I suspect we'll learn more with every year that people continue to do research. And so what we've prioritized is the ability to deploy a new measure into the clinical workflow every night, based on definitions that other people in the world come up with as being important. And that's a significant computational problem in an EMR, which you've got tons and tons of data. How do you scrub every patient chart in a timely manner? And how does it re-scrub every single time you open or modify the chart? And we've prioritized making that a real-time event, so the physician always sees where the patient is. And I think that that is what platforms will need to be. That is a foundational competency, I think, of all health IT platforms, is that it cannot be, let's run reports once a month, and then let's have meetings with doctors, and then let's see how we get better. I think we've tried that for a really long time. I think we have to be much faster to get new knowledge out to physicians in particular about what they should be measuring.
Mm-hmm. And I just want to add, in terms of some of the work that I've been looking at lately, is getting the observations of daily living, consumers, patients, caregivers, people's daily perceptions of whatever the problem is that you're measuring, you're looking at, getting that perspective into the measurement, because people have been overlooked in the blood pressure scores or whatever. So a simple mood app that can be voted on, in a poll. There are some great ways to use mobile to get the person's point of view into the grading and the scoring. Another question?
He's over there. He's
Sorry.
next.
Hi. Yeah, I have a question actually for Jeremy, because I regard the Athena Health platform as probably one of the most interesting in healthcare. And that has to do with this notion, we have a title, accountability, value-based care, and changing clinical practice. So I'm not concerned about workflow and the like, but what I'm interested in is, to what extent are you identifying or profiling your individual client or provider with best practices across, as has been identified, across your customer base? And to what extent does your individual client, physician, for example, ask you to do that, as opposed to resist doing that? Because one of the things I found as being critical in driving change is transparency, data-driven transparency. Everybody in healthcare is above average, and I haven't figured out yet how.
Yeah, that's a great question. So I think, so I'm blushing, thank you for your respect for Athena, but I think one of the things that has been a game changer with meaningful use actually is the idea that there are a set of standards that you have to perform against. And we model roughly 50 different payer-sponsored pay-for-P programs in our system. And we make that, that's a real time, every time you open a patient chart, you see how you're doing against those measures. And one of the standard dashboards in the system is, we call it the quality management dashboard, which is sort of it shows all the physicians in a given department, and it shows how they're doing against various programs. And we don't hear, no one has asked us to turn that off. And so, it's the playing field, there's a game layer emerging in healthcare around these quality measures, and I think that I think everyone's expecting to see them. I think that one of the more interesting things that we've done has been with University Hospital out in Cleveland, and with a company here in Boston called Kairos, which is all about matching patients and providers together. So we send them a feed of data from our EMR, and they have some proprietary algorithms about that get to clinical quality measures, but also just availability. And then in the scheduling module of our system, they recommend the scheduling person gets the right doctor for that patient. I think we're going to see a lot more of that because I think in some ways it's more actionable, right? So driving volume to patients, to providers who are the right provider for that patient. I didn't catch it.
How treating his diabetes.
Oh yeah, we do. Tons of that. So all the CQMs in the Meaningful Use program, that's just a core foundational competency that you should expect in any EMR today. Is how are you doing on those core clinical quality measures?
So you know what, Steve, why don't you ask the question at the end after the session? But because there are two people standing up here, this session, the time is over. I think for the benefit of the audience, it would be good if each one could ask as succinctly as possible their questions. Let's hold an answer, but just get your question out if you could.
Thank you. First of all, I'm Davis Graham. I'm from representing Brandeis University as their scholar, which I'm very thankful for. I'm also in outpatient radiology. The cost of healthcare, everybody says, is going up and up and up. Yet at the same time, our reimbursements have gone down by 18%. So I think the biggest issue is the payment issues, that the way that we're structured. What the previous speaker in the
AAA.
Show me the money.
Right.
Yeah, he
Is that the question?
Right.
No, it's the fact that there was not a payment system up there. It was already paid for. What is your all's thought on that? Thank you.
Okay. And the next question?
Hi, Jonah Comstock, Moby Health News. I wanted to respond to something Jeremy said about how not Epic, thinking about yesterday, how Athena Health iterates on the technology after releasing it into the wild, which is a very common thing in tech. But in healthcare, there's also this sense that you don't want to release your technology into the wild until you're sure it's going to do the best for patients and do no harm. So I was wondering if the panel would talk a little bit about that push and pull between, that minimum viable product tech idea and that, it has to be perfect the first time healthcare idea.
Wow.
So I think that the answer to both of those questions is interesting, and I want to encourage people to come up if you guys could stay a little bit longer, and let everyone know that sessions are over until 10:15.